If we could come back together, we'll finish our case studies. So lots of good discussion during the break, and some of the stuff we're going to cover as we go along here. So let's start with case number 2. This is a patient that's 66 years old, and on March 2nd, they go to the OR for an exploratory lap, and they insert a Foley, and the patient is transferred to the ICU post-op. On the 3rd, the patient is stable, and the Foley is in place. And on the 5th, they still have their Foley. The patient is febrile on this day and complaining of pain in the right lower back. The WBCs are increased to 19,000. He has cloudy, foul-smelling urine, and a urine analysis shows 2+ protein and nitrite and 2+ leukocyte esterase. WBCs are 15 millimeters cubed of unspun urine and 3+ bacteria. Culture was positive for greater than 10,000 colonies of E. coli. So this is a voting question. Is this a CAUTI, and if so, what type? So your choice is no UTI, or that this is a UTI that's not catheter-associated, or it is catheter-associated and it's CAUTI 2A, or that it's a catheter-associated ABUTI. Okay, let's see what you say. 97% say that this is a CAUTI 2A and it's catheter-associated, and you are correct. You guys got that pretty well. So let's look at the rationale for this. In this case, the UTI criteria were not met in the POA time period, first 2 days. It's catheter-associated because the date of event is 3/5, which was Foley day number 4. Okay, and I do want to clarify, actually, this is one of the questions that came up. In this case, they documented right or left lower back pain. I'm sorry, they documented right. Do they document right? Either right or left lower back pain would be pretty synonymous with flank pain or CVA pain. So we do allow you to use that. However, if you just have lower back pain, we can't really say that that's specific enough to say that this is CVA pain because, could be from laying in bed, could be, it's not. We need more details that it's in this flank area. So similarly, sometimes we get questions about abdominal tenderness. Can you use abdominal tenderness to meet the suprapubic tenderness? And the answer would be no. It's pretty general terminology. If they said bladder tenderness, that would be acceptable. Okay. And they had urine culture was the lower colony count, but they had positive dipstick and pyuria to meet the criteria. So. Okay, case 3. It's a 58-year-old patient that's admitted to the ED with a GI bleed, and they insert a Foley. On the 2nd day, the patient spiked a temp of 38.6, and the indwelling catheter remains in place, and a urine specimen is sent. Culture results are 100,000 of Pseudomonas aeruginosa on day 3. That was collected on day 2. They're afebrile on this day and asymptomatic, and antibiotics are started. Day 4 and day 5, the patient is asymptomatic and afebrile. So is this an HAI, and if so, what type? This is a healthcare-associated UTI, but not a CAUTI, because the catheter had not been in place for greater than 2 calendar days, or no, it's a UTI that is present on admission, or it's a CAUTI CAUTI criterion 1A. Okay, let's see what you say. The answer is 2. It's a UTI that is POA, and 70% said that. Almost 20%, however, said it was a CAUTI CAUTI criterion 1A. So let's look at this. Patient meets CAUTI 1A criteria on day 2 of hospitalization. So they had a temp, and they had a positive urine culture on day 2. That is within the POA time period. Curious, does anybody that got that wrong unclear on that? So again, determine if the POI criteria are met. If they are met, if they're not met, then you set aside all those days. This is the way I think about this. If they don't meet POA criteria, set aside those first 2 days. Don't even look at them anymore and consider it. Just look at the days after that. Any symptoms that were only present during those first 2 days are not going to be able to be utilized to meet the HAI definition. If they're still present, if they were present in the first 2 days, and when you're looking at 3 days, day 3 and on, if they're still present, they can be used to meet the HAI criteria. So if that helps you, that helps me when I think about it. I determine if it's POA. If it's not POA, I stop looking. I don't even care what happened in the first 2 days. Okay, it's my funny email. Janet stole my joke. This is an email that we got from somebody on the subject of SSI reporting. This is a user email. Could you help me with the definition of some examples of stab wound infection? Does this stab mean laparoscopic or like a street fight and an ice pick is used? I thought, then I looked for clip art on ice pick, and I thought I'm not going to be able to find a picture of an ice pick. Who uses an ice pick anymore, right? But I found one. So, all right. Case 3, continuing case 3. On the 16th day, the Foleys remained in place. The patient completed treatment for the UTI that was on hospital day, and they completed that treatment on hospital day 11. They did develop a DVT. They have been afebrile till today, but the temp has been edging up the last 2 days and is now 38.1. And they have a yellow productive cough and rhonchi present. The urine is cloudy the next day. The fever is 37.9. Continue to have the cough. They collect urine and sputum cultures. The next day, both urine and sputum cultures are positive for Staph aureus with greater than 100,000 in the urine. So now we're going to ask this question about, is this an extension or is this a new infection? So do they have a CAUTI? Yes. The first UTI was resolved and the treatment was finished. No, it's an extension of the first UTI. Or no, the UTI is secondary to a respiratory infection. You can vote. Okay, let's see how you did. 84% of you said that the first one was resolved and the treatment was finished, so this is a UTI, a new UTI, and that is the correct answer. They completed their treatment, the symptoms had resolved, and only to be followed by onset of new symptoms and criteria are met, so it's a CAUTI. And I do want to say that sometimes people think that, like CLABSI, you can say that a CAUTI is secondary to another site of infection, and that is not the case in NHSN. There's no secondary UTIs for reporting purposes. And our favorite rule of all, that the fever cannot be attributed to another source of infection. This information is, if any of you are interested in looking at it, in as far back as the March 2012 newsletter. And there's also, if you look at the criteria, you'll note that there is no asterisk following the fever, and I think I highlighted that earlier. So, right, another email. I have my CLIP ICU data for May. Is it possible to fax or mail you the data? I am one-person department, and with H1N1 going on, it would be much easier for me as opposed to fitting it into a format. No. Wouldn't that be nice? All right. Case number 4. A 76-year-old woman is admitted from an LTAC at 8 a.m. for a surgical debridement of a sacral decube. Medical history is notable for severe rheumatoid arthritis. She has congestive heart failure and atrial fibrillation. A routine admission UA performed was positive for leukocyte esterase and 3 WBCs by high-power field of spun urine. Patient is afebrile, denies any urgency, frequency, or pain. No suprapubic or CVA pain included. The Foley catheter was present on admission, and a peripheral IV is inserted in the OR. She is admitted postoperatively to the telemetry unit. The next day, the wound care specialist documents that the wound is clean, the temperature is 37.4, the Foley is draining cloudy urine. The next day, she is transferred to a surgical unit. They must not have had room for her, or I guess she got stable enough to be transferred out of telemetry. A temp of 37.9, the Foley is removed, and she's encouraged to push her PO fluids, and they send a urine culture for lab, and for sensitivity also. On the 8th, the patient complains of dysuria and pain with palpation to the suprapubic area, and they start Bactrim. Her urine specimen sent on 4/7 results are positive for E. coli greater than 100,000, and the patient is afebrile, and she's preparing for discharge back to the LTAC. So, voting question, does the patient have a UTI, and is it a CAUTI? So you can say no, it was present on admission. Yes, the patient has a SUDI 1A and it is catheter-associated, or yes, the patient has a SUDI 1B, but it is not a catheter-associated UTI. Okay, so let's see how you did. Again, we had a split decision here. 70%, almost the same amount as last time when they were split. 70% thought that this patient has a SUDI 1A that is catheter-associated. And that is the correct answer. So let's look at why. Criteria were not met in the POA time period. So if we go back. Patient came in on 4/5, and met criteria on, it looks like 4-8. Is that right? Yes, when they had dysuria and pain after the catheter was taken out. This is therefore a CAUTI. They met the criteria for the UTI on the day after the catheter was removed and the catheter had been in place for greater than 2 days. So just a note that, UAs might be positive for many non-infectious reasons, especially somebody that's coming into a facility with a Foley that's been in for a long time. They probably will have a positive UA. That catheter itself can cause, the formation of WBCs. So don't take that as in and of itself that the patient has a UTI. Okay. Which location would the CAUTI be attributed? Telemetry or surgical unit? Oh, it doesn't look like the voting is working on this one. For some reason, sorry. So we'll just go ahead and answer it. It's going to be attributed to the telemetry unit. The date of event is 4-8, which is the day after transfer from the telemetry unit. Okay. Okay. Case 5. On May 15th, we have a 48-year-old male that's involved in a motorcycle accident with a closed head injury, multiple fractures, taken to the OR for open reduction internal fixations and evacuation of a subdural hematoma. Foley catheter and left subclavian catheter had been placed in the ED. The patient remains on the ventilator that was placed in the OR postoperative, remains on it postoperatively, and the lungs are clear bilaterally. 6 days later, on May 21st, temp max is 99.8. Lungs are still clear. Foley is still in place and draining. Clear yellow urine. Patient is still on a ventilator. Sputum production is slightly increased. On May 22nd, the patient has a temp of 100.4 Fahrenheit. Vent settings are stable. There's no change in the sputum. May 23rd, temp remains the same. WBCs are 14,000 and the lung sounds are clear, and the chest x-ray is clear. Patient's still on the vent. The Foley and the central line are still in place, and they pan culture the patient because of the WBCs. Empiric antibiotic treatment is begun. On May 24th, the urine culture is greater than 100,000 of Pseudomonas aeruginosa, and the blood culture is also positive for the same organism. Physical assessment is normal. There is no patient response to suprapubic or costovertebral angle palpation. So, does this patient have a UTI, and if so, what type? And it looks like the voting is working on this one. No UTI, an ABUTI, a SUTI 2A, or a SUTI 1A. Okay, let's see what you have to say. Oh, split here. 60% say it's an ABUTI and 31% say it's a SUTI 1A. That's interesting. So the actual correct answer is it's an ABUTI. The patient didn't have any UTI criteria symptoms in the presence, and there was a positive blood culture matching the urine culture. That makes this an ABUTI. Note that the fever has to be greater than 100.4. Tricky, huh? To meet the fever requirements for NHSN definitions. And this was 100.4. Is the catheter-associated ABUTI reportable if the CAUTI reporting is in plan for the patient's location? So are ABUTI, catheter-associated ABUTIs reportable? And this is not voting, so you can just yell out. Yes, absolutely. They have to be reported if you have in-plan CAUTI surveillance marked on your monthly reporting plan. Some facilities think they just have to report SUDIs, but that's not the case. Okay, you ready for another? Are these funny to you? Because they're funny to me. I don't know. Sometimes we don't answer them. Usually we don't answer them. So this one is, I thought this was just funny the way they wrote this. The cardiothoracic surgeon also noted that the patient's prognosis was quite poor unless dramatically improved. Okay. Thank you, Captain Obvious. All right. Case number 6. On 8/25, we have a 73-year-old patient in the neurosurgical ICU that's admitted following a cerebrovascular accident. He's ventilated, he has a subclavian catheter and a Foley catheter inserted on admit, and he's reacting only to painful stimuli. On 9/2, so what is that? 8 days, 7-8 days later, the patient has the white cells are slightly elevated at 12,000. Temp is 37.4 Celsius. The urine is cloudy. The lungs are clear to auscultation. They're still ventilated and still catheterized. The next day, WBCs go up to 15.8. Temperature max is 37.6, so they're not febrile. Breath sounds are slightly coarse. They have some minimal clear sputum. The urine is unchanged. They do a UA. And they also send endotracheal and urine specimens for culture. There is no suprapubic or CVA pain noted. On 9/4, the urinalysis is positive for leukocyte esterase. The nitrates and the WBCs are too numerous to count, and the blood and the endotracheal cultures, no growth. The urine, however, is positive for 100,000 of ephesium. So does this patient have a UTI? And it looks like the voting is working. If so, what type? You can say they have an ABUTI, they have a SUDI 1A, a SUDI 1B, or no UTI. Okay, let's see what you think. %72% of you say there is no UTI, and you are correct. There's no urinary symptoms. There's no fever greater than 38 Celsius. There's no matching blood culture to the urine culture, so there's no UTI by surveillance criteria. Very good. So, like I said, surveillance definitions work better in some patient populations than others. You know, we do want to make sure that even our patients that are ventilated are getting thorough assessments to look for the UTI symptoms other than fever. Sometimes some facilities have had to have dialogue or education with the clinicians. And, you know, I'm not going to beat a dead horse and tell you that surveillance definitions have to be followed. Okay, Grandpa Unlucky. On March 1st, Grandpa Unlucky has now been in your medical ward for 4 days. He had his Foley catheter, which was placed on day 1, is removed today. He's found to be severely anemic and is transfused with 2 units of blood. Grandpa has been having trouble voiding the next day on March 2nd and has not felt that he's been emptying his bladder. He's catheterized post-void and 600 milliliters of residual urine is collected, and the Foley catheter is left in place. On March 3rd, he complains of tenderness upon suprapubic palpation. His urine is sent for culture and is reported as positive for 100,000 of ephesium. Does Grandpa Unlucky have a CAUTI? You can say yes, a CAUTI 1A, yes, a CAUTI 2A, or no, his UTI is not catheter-associated because the new catheter has only been in place 1 day. Okay, let's see how you answered. 82% said that this is a CAUTI criterion 1A, and that is the correct answer. Good job. So why? He didn't have a POA UTI, wasn't in the first 2 days. Foley was in place for 4 days on March 1st when it was removed. Then it was replaced on March 2nd, the next day. So this is now Foley day 5 since there was not a full calendar day without the Foley. He meets CAUTI criterion 1A with a suprapubic tenderness and a positive urine culture of greater than 100,000 on Foley day 6, March 3rd. Okay. Very good. Case 8 is our last case, and then I'm going to give you guys a little bit of information about what the CAUTI review group has been doing, because I know you're all interested in that information. So, case 8 is a 59-year-old female that's admitted with uterine cancer and has a Foley inserted on admit. She has a total abdominal hysterectomy performed the next day, and on the 18th, she's progressing well until she has a fever spike of 101.3. Blood specimen is sent, and results are no growth. I'm assuming that her Foley is still in here. I don't say that, but we'll say that it is. On the 19th, she's asymptomatic. On the 20th, she's asymptomatic. On the 21st, they send a urine specimen. Maybe her WBCs are elevated. And the result is 10 to the 5th of E. coli. She's then asymptomatic on the 22nd and the 23rd, and they took out her catheter on the 23rd. Does she have a UTI, and if so, what type? She has an ABUTI, she has a CAUTI 1A, or a CAUTI 2A, or she has no UTI. Okay, you guys voted quick on this one. 94% said she has no UTI, and you are right. Good job. There's more than one gap day between the date of the fever and the date of the urine culture, so I get my pointer to work here. Fever, asymptomatic, urine culture, so there's more than a single gap day here. And then, you know, if she had a fever on this day, she would have met criteria here, but she is asymptomatic here and she's asymptomatic here. So you have to look, you can't just stop looking at this urine culture there's a fever here, and then you get urine culture, and you say, oh, she doesn't meet it. Then you have to look, does she meet it here or here as well with the urine culture? So that's why I included those last 2 days. That sometimes patients or users send us the information and they don't provide that information. It makes us worry that they're forgetting to look past that culture. I have gotten a couple questions about the order of elements. Can they have the culture first and the fever later? The answer is yes. Maybe they're collecting the urine culture because of an elevated WBCs and they just haven't started their fever yet. There's no specific order that they have to occur in. Okay, so you guys did a great job. And I do want to give you some information about the definitional update for CAUTI to tell you where we are in that. As I said, we started the work in 2012. The definition was last updated in 2009. User concerns, boy, these are a surprise. We haven't heard these today, have we? Clinical correlation, concerns about the fact that it doesn't seem to be have good clinical correlation. As I said, we've heard about lack of sensitivity in specific populations. I was telling somebody during the break, their concerns were that we were overcalling, but we also hear from other people that they believe that they're being undercalled. And some people that are looking at these pretty systematically are telling us that they believe that they're being undercalled. There is some lack of specificity related to, this issue of a fever being due to more than one cause. And specific candida organisms that are pathogens, specifically candida. What is the true clinical meaning of candida in the urine? We've had our group that we pulled together included a lot of the top experts in CAUTI surveillance. Dr. Sanjay Saint was involved, Dr. Mohammed Fakai from the University of Michigan, very published and knowledgeable people. And honestly, there was a discussion and a debate about whether or not candida should be removed. It wasn't across the board to believe that we should stop collecting those, and there has not yet been a decision about that, but it is something that is being considered. And the other organism that we hear some questions about is Staph aureus. Medical physicians are trained that if a patient has Staph aureus in the blood or in the urine, that you should look to the bloodstream infection to make sure that that's not being seeded more often from the blood to the urine with that organism. And as you know, Staph aureus is currently included in the definition. So that is a concern that we have heard from users. So this work has taken place with teleconferences with subject matter experts. I know that Lauren is here in the audience, and possibly a couple of other people that were included on this on these teleconferences. They were a couple of times a week. We were meeting a couple times a week early on. It included IPs, it included epidemiologists, it included state health department individuals, microbiologists. A big part was a microbiologist input on this. And we did an evidence review of what is out there to better inform our decisions. Also, we collaborated with APIC to discuss, to survey facilities about their laboratory culture practices, especially around Candida. Did any of you participate in that? Very few. Wow, surprising. That's unfortunate. We have the data collected. It's being analyzed right now. It's target date is to have it finished analyzed this month. And then we're hoping that the results of that will help us to create a definition that is can be consistently applied by all facilities. We've gotten a lot of feedback from facilities that their culture results are not reported out, so that they can meet, for instance, CAUTI criterion 2A. They don't get those culture results that are less than 10 to the 4th or 10 to the, they don't get all of this. Or their WBCs that in the urinalysis are reported differently than our ranges are. So we were trying to we're collecting information about how the labs are reporting those and utilizing that, because we want to make it, whatever we end up with the definition being, we want it to be as fair as possible for all of the facilities. We also had one of our EIS officers who went and provided an epi aid with a facility that had a very high SIR for CAUTI. And in addition to doing the epi aid and helping them identify prevention efforts, she was able to collect a lot of information that's going to be very useful to us as we look at the definitions. Interestingly enough, one of the things that she found, which was kind of puzzling, was that there were a lot of patients that were end-stage renal patients that had Foley catheters. And that seemed kind of odd and problematic. And they were often sending urine cultures from these patients. And the term that I heard, I'd never heard it before, was, well, that's bladder sweat, that's not urine. These people don't make urine, that's bladder sweat. And we shouldn't be culturing it. So, you know, there's some interesting things that I think are going to come out of that epi aid, the analysis of that. And that facility has actually already started to make some changes, and they have brought their rates down quite a bit. Some of the changes that they looked at were using a reflex UA to decide whether or not to send a urine culture, so they've really backed off on the number of urine cultures that they're sending. I think that was, I know there was another change that they made, and I just can't think of it off the top of my head, but that was one of the bigger ones that they've instituted. And we're also collaborating with the CUSP CAUTI group. How many here are involved in CUSP CAUTI? A lot more of you, okay. And we're getting great data from that group and using their findings from that to better inform the decisions that we're making as far as how to update the CAUTI definition. So we're anticipating a two-step process. A short-term update for 2015. We want to address the issues in 2015 that will even the playing field, that will bring the clinical and surveillance determinations closer to the extent that we can do that together. And again, we have to make sure that these changes are still feasible for collection for you guys, because I know nobody is sitting around out there twiddling their thumbs and is asking for more data pieces to be collected. So we have to make sure that anything we include in it is something that's easily accessible by everybody and is not overly burdensome. The long-term goal is that we're going to have an electronically collectible CAUTI definition, okay? But that may be 5 years down the line or wherever. That's the long-term plan. Right now, we're just for 2015, we're trying to get this an improvement in the definition so that you know, it's a little more fair and it's a little more relevant to what you're doing and how you're using it. I hope to have more information at APIC 2014. So if any of you are coming there, you know, come and hear what we have to say. I included this slide, you know, just for those of you that are struggling with this, things that you might think about doing. You know, I can't say that these are hard recommendations. I can only tell you that these are some things that some facilities have found that have helped. As I said, reflex urine cultures, sending the UA along with the culture and only performing the culture if the UA is positive. Maybe discussions with your physicians about how they're culturing, why they're culturing, are they culturing too much? Changing long-dwelling catheters before collecting the urine to exclude colonization. Obviously, if the patient's had a catheter in for 2 weeks and you pull a culture from it, it's probably going to be positive. So let's not try to do that, although I'm going to say that I'm talking to someone here that has been doing this, and she's interestingly said that she thinks that she's starting to see maybe her rates creep up because she's not sure that people are using good technique when they put the catheter back in. So, and you know, in addition to the prevention efforts, strengthening these diagnostic practices will help to improve the CAUTI rates. You know, if we don't collect unnecessary urine cultures, you don't have a urine culture, you don't have a UTI. So we want to get rid of the unnecessary ones. That will also increase the patient safety because we won't have all those adverse events that go along with unnecessary treatment. And really important, it's going to increase your staff morale, because I hear you guys saying, and we all hear you saying, you know, our people, we are dedicated to this. We are trying to lower our rates, and it's very hard on staff morale when we have to identify these things as CAUTI, and we don't clinically believe they are CAUTI. So we do hear you. These are some things that you may be able to do to help that. We're working on the things that we are able to do to try to help that also. And I hope you hear that from me, because it is very true. Okay. The last funny email, and then we'll have time for questions. I thought you would enjoy this one. I think they meant to hit forward, but they hit reply. Dear NHSN, this is what we sent out. Dear NHSN safety component users, in January 2010, NHSN will be changing the specimen source codes list that's used for lab ID event reporting. The change is being blah, 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 blah. So that's what we sent out. We sent it as a blast email to everybody that does lab ID. And this was the response that we got. Sue, what is all this about? I'm sick of NHSN already, and we haven't even started. So we didn't respond. So with that, I will open it up for questions. Can you flick? Is there there should be a button there, yeah.
Can you hear me now?
Yes.
All right. This is more just a comment. I'm, looking at the subtleties within these definitions. I think that when we have the VAE calculator and we have a lab ID calculator, I think a CAUTI calculator should be next on the data gnomes wish list, because because I think it would, in fact, streamline a lot of these questions and concerns when you have this, skip a day, add a day.
Absolutely. And we're talking about that. I think we want to get the definition fixed and then do it.
I realize you want to have it tied down
absolutely.
first. Yeah, you want to have it tied down before you do that, but I think that would be a great thing to use.
Yeah,
Thank you.
We agree. Yes.
I have a question about the transfer rule for the patients who are transferred twice in one calendar day.
Yes.
Just on the rationale on that, on Wednesday, you said that the rationale is you attribute it to the unit that they had the most exposure on. And then today you said you attribute it to the unit that they were at first, the first unit before transfer.
Okay. I don't think I said that he had the most exposure. If I did, that was a mistake.
That's what I heard. So I just wanted to make sure I didn't hear it
no,
incorrectly.
I think the rationale that we used is just that it's the farthest one back during the transfer time period, and so we're figuring that's got the longest exposure. We don't want to attribute it to the most recent transfer, so we're going to go back to the
And that makes
latest
complete
one,
sense.
yeah.
I just wanted to make
So
sure I
I'm sorry
understood.
if I said that. I was incorrect if I did.
Thank you.
Yeah. Anybody else? Okay, well, we're going to finish early, but Janet has an announcement that she wants to make. Thank you very much this morning for all of you. Appreciate it.
Okay, so I wanted to get this on the record. Since so many of you are doing H-Pros and K-Pros, at the end of the presentation, someone said, wait, was that supposed to be an and between the C-reactive protein and the ESR? And I then had a moment of, oh my gosh, I think these were all ors, and I went back, and the physician I worked with and who worked with MSIS was here, and he goes, yes, you were correct, Janet, it should have been an or. So I'm like, great. I messed up the 100, should have been a 10, it was supposed to be an or. So then this morning, of course, I'm losing sleep over this, and I emailed him very first thing and said, did I really mess up two things in our new PJI definition? So I sent it to Dr. Fagan. He's wonderful to work with. And he goes, Janet, nothing is wrong in this definition. I apologize. I should not have told you it was an R. It is supposed to be an and, so that is correct. It is supposed to be and in criterion B, your C-reactive protein and. And then the greater than 100 is correct. We had, when we first wrote this, we worked on this for a while, we had it at greater than 10. And then when the MSIS met again a final time, we realized the C-reactive protein greater than 10 definition is really pointing at chronic knee infections. Their acute definition for an acute knee infection is a C-reactive protein of greater than 100. So everything's fine in your PJI definition. And we apologize for any confusion about that. And I will as well put that into our errata newsletter that the current PGI definition is correct. It's the and it was only kind of mentioned here, but that greater than 100 is correct because that's evidence of an acute knee infection. Okay, I hope that helps clarify that.